Hello, everyone. Welcome. We'll give everybody a few seconds to join in. I'm so glad you can join us. This is Robin Luther. I'm with Susan G. Komen in Wisconsin, and I'm delighted to welcome you to the 2020 Metastatic Breast Cancer Impact Series. Hopefully you've had a few other opportunities to see our recordings of the sessions you may have missed, or perhaps you caught them live. We're so glad you could join us today for our session titled Tell Me More, What's New in Metastatic Breast Cancer. My pleasure will be to introduce our speaker, Dr. George Sledge. He's had a slight delay, but we have his presentation recorded, and he will join us for a live question and answer session as soon as he is able. Let me give you a little background on Dr. Sledge. Dr. Sledge Jr. went into medicine to help people, and those he wanted to help most, he realized early in his training, were cancer patients. He has devoted his professional life to understanding the biology of cancer and working to improve treatments specifically for breast cancer. Dr. Sledge Jr. MD is Professor of Medicine for the Division of Oncology at Stanford University. He's an internationally recognized clinical trialist and a pioneer in the development of novel therapies for breast cancer. Dr. Sledge directed the first large nationwide trial that studied the efficacy of paclitaxel, I hope I'm pronouncing that correctly, as a therapy for advanced breast cancer. He has led many nationwide clinical trials involving new therapies for breast cancer, and his research focuses on molecular and tumor biology, growth factors, and targeted therapy. His Komen-funded research focuses on new technologies that capture tumor cells circulating in the bloodstream, which may provide doctors with better tools to understand and treat metastatic breast cancer. Dr. Sledge is also one of the experts involved with Komen's Big Data Initiative. He was awarded the Brinker Award for Scientific Distinction in 2006 for his outstanding research, and is just one of our most valuable Susan G. Komen assets. We are so delighted that you're able to hear from him today. Before we start his presentation, a quick note to all of our viewers. There's a Q&A button near your presentation screen. As questions occur to you during the talk, please add them to the question and answer session. The chat section is disabled, so don't add things there. But put in anything you think of, and then at the end of the presentation, we'll have a live Q&A session. And then you can also continue to ask questions then. So I hope you enjoy this presentation. Let me share that video with you right now, and we will get going, and Dr. Sledge will join us as soon as possible.
Hello, friends. It's a genuine pleasure to talk to you today about metastatic breast cancer and to bring you up to date on what's new in this area. I'm George Sledge. I'm a professor of medicine at Stanford University, and I'm co-chief scientific advisor for Susan G. Komen. I'll also add, since I'm speaking to friends in Wisconsin, that I grew up as a Badger in Madison, and I'm a graduate of the University of Wisconsin at Madison. So hello, friends. Here's a few disclosures. So I'd like to start here. If we look in the United States, somewhere over 40,000 men and women die every year of breast cancer. So why can't we cure metastatic breast cancer? Why, despite generations now of research, can't we do it? And the answer in truth is that we already cure some patients with metastatic breast cancer. And that is to say, we kill off micrometastatic cancer cells with adjuvant therapy. There are occasional patients with metastatic breast cancer who receive chemotherapy and go into a prolonged remission that never ends. And increasingly, I would say, with HER2-targeted therapy as well. There are patients who have single sites of metastasis where it appears we can cure some patients. And indeed, patients who suffer a local regional recurrence of their cancer, we know from a trial called CALOR, frequently can do quite well. So the question is not, why can't we cure, but rather, why don't we cure more? Why are we limited in terms of our ability to take care of this awful disease? And let me give you an example of this. This is from a very interesting study that was done in Japan by Dr. Kobayashi there, who looked at patients who had a single site or a very small number of sites of metastatic disease. These patients would receive some therapy such as surgery or radiation therapy, and then would receive appropriate systemic therapy. And as you can see, there's a percentage of patients, it's probably somewhere in the range of a quarter to a third, who even 10 and 20 years out appear to be doing well. So there are some metastatic cancers that indeed appear to be curable. Unfortunately, that's not the case for most patients with metastatic breast cancer. And so for most patients with metastatic breast cancer, we have to ask the question, what can we do not to cure, but to prolong life? And again, towards the end of my talk, I'll make some suggestions as how we can move again towards the idea of a cure. And the important thing that we've learned in the last few decades about breast cancer is that it's not a single disease, but rather a family of diseases. And this family of diseases includes a group of breast cancers that are estrogen sensitive, and we know this because they have a biomarker called the estrogen receptor. There's another group of breast cancer patients who are positive for a growth factor receptor called HER2, and then there's a third group of patients, sometimes called basal or basaloid, in the laboratory, or triple negative breast cancer in the clinic, who represent a separate challenge. And knowing which cancer your cancer belongs to is crucially important in terms of treating the cancer. So what I'd like to do throughout much of this talk is actually to go through these different subsets of breast cancer and to give you some idea of the very real progress we've made in recent years. So let's start with estrogen receptor positive breast cancer. Something that we've known for a very long time now is that estrogen, female sex hormone, circulating in the body will freely cross into a breast cancer cell. And if that breast cancer cell contains an estrogen receptor, it'll bind to it, transmit itself into the cell nucleus, and tell the cancer to start dividing. Now, we've also known for a very long time that if we block estrogen, and we can do this through drugs such as the anti-estrogen tamoxifen, or reducing circulating estrogen levels with drugs such as aromatase inhibitors in postmenopausal women, or shutting off the ovaries in premenopausal women, that this indeed can shut down cell proliferation, cell growth in breast cancers. And this major advance, which occurred now over a generation ago, has been applied to early stage breast cancer to cure some patients, but also has been applied to the advanced stage disease to shrink tumors and prolong life. Now, one of the major advances in recent years that has added to this has been the recognition of something called CDK4/6. And here a little bit of biology. Estrogen, when it binds to the estrogen receptor, sets off a whole series of downstream events, inducing something called cyclin D, which then turns on something called cyclin-dependent kinases 4 and 6, which in turn tell the cancer cell to start growing and dividing. Now, everyone goes to sleep when they see something like this. So let me put it a little bit different way. So imagine that the breast cancer cell is a freight train going down the tracks. Think of estrogen as coal that's being put into the furnace. And the furnace is the estrogen receptor, okay? But obviously there's more to a train going down the track than just the coal going into the furnace. Beyond that, of course, we have all gears and levers and wheels that move the train down the track. And these are the parts of the cell division process that drive the train down the track and drive the cancer to divide and grow. And so interfering with parts of these processes can be valuable in terms of helping to shrink the tumor. And that's exactly what drugs called CDK4/6 inhibitors do. Now, there's 3 of these drugs that have been approved by the Food and Drug Administration, palbociclib, abemaciclib, and ribociclib. Their chemical structures are shown here. I'll ask you to memorize them in the 10 or 15 seconds that the slide is up in front of you. These are all drugs that we know are active for patients with advanced breast cancer, and that's the important thing. And these drugs differ a little bit in terms of their side effects. Some of the drugs are a little bit more in terms of causing white blood cell counts to go down. Abemaciclib is a little bit worse in terms of causing diarrhea. Ribociclib can cause some EKG changes, some cardiac rhythm disturbances. But in general, these drugs are working pretty much the same way. And in general, for the average patient on the drug feels probably pretty much the same. If we look at these drugs, we now have a number of clinical trials in the setting of metastatic breast cancer, where in each and every one of these trials, we've been able to see that adding a CDK4/6 inhibitor to standard hormonal therapy, in this case, an aromatase inhibitor in frontline metastatic breast cancer, adds roughly a year's worth of time that the patient's tumor will remain progression-free, roughly a year before the tumor starts growing again. And this was the initial basis for the approval of these agents by the Food and Drug Administration several years ago. Now, in addition, for patients with more advanced disease, where they have an estrogen-sensitive tumor, where their tumor has grown on an aromatase inhibitor, if we add a CDK4/6 inhibitor to fulvestrant, a standard hormonal therapy in this setting, we also improve progression-free survival by varying amounts based in part on how heavily pretreated the patient has been. But again, the Food and Drug Administration approved these agents in this setting based upon this data. And yours truly has the pleasure to have been the principal investigator on the middle study, the Monarch 2 study that is shown here. Now, with further follow-up, we know that these agents not only improve the length of time a patient goes before the tumor starts growing again, they also appear to improve overall survival. And while this data is not yet mature, for trials such as this MONALEESA-7 trial, a trial done in younger women, or in the Monarch 2 trial that I ran in older women with more advanced disease, we're now seeing evidence of an improvement in overall survival. And these improvements vary based on the stage of the disease, and based on what prior therapy the patient has received. But we're clearly able to improve overall survival. And many patients do well for many years with this approach now. Now, this is not a cure, I would hasten to add. This is an improvement in survival. So we still have real work to do, both in the laboratory and in the clinic. But this is a real advance and certainly will affect patients around the globe. I would add that these same agents applied to early stage breast cancer, we now know, appear to reduce the number of patients who are having a relapse of their disease. And so possibly, just possibly, this may improve the cure rate for patients with early stage disease as well. So let's move on. I've mentioned CDK4/6 inhibitors, but that's not been the only advance that we've seen in recent years. What we see now is that targeting more than one growth factor receptor may be important in terms of being able to shrink breast cancers. And so if you think of estrogen binding to the estrogen receptor and then going to the cell nucleus, blocking estrogen is certainly one way of improving things. But we also know that growth factor receptors of other sorts can also signal the cell nucleus through what's known as crosstalk, using intermediate enzymes with funny names such as PI3 kinase, AKT, and mTOR, and that we can target these pathways. And if we target these pathways and target both the estrogen receptor and the other growth factor receptors, that can actually improve our ability to shrink the tumor and to kill breast cancer cells. And we've looked at this now with a number of different agents. The one that was most recently approved by the Food and Drug Administration is a drug called alpelisib, which targets what's known as PI3 kinase, an important enzyme that helps signal in estrogen receptor positive breast cancer cells to overcome resistance to hormonal blockade. And a large phase 3 trial that compared PI3 kinase inhibition to just hormonal therapy alone was able to show that we can improve, in particular with patients who have the mutation that underlies the PI3 kinase, what's known as PIK3CA. We can improve how long patients go before having progression of their disease. And emerging evidence would suggest this is likely to improve survival as well. So this is one of a number of advances in this area where shutting off dual signaling to the cancer cell nucleus in estrogen-sensitive patients may improve outcome. And again, something that's been exciting for many patients. And as I mentioned, we now have some evidence, some early evidence, that this will also lead to improvement in survival for patients with metastatic breast cancer. We're still waiting for further emerging data, but right now it's starting to look pretty good. Now, I mentioned alpelisib. There's another drug coming along right on its heels that targets something called AKT. This is part of the same signaling pathway where we do dual blockade of both the estrogen receptor and this other pathway. This is a drug with a really unpronounceable name, capivasertib, or CAPI, as breast cancer doctors tend to call it. Or if you combine it with the hormonal therapy fulvestrant in metastatic breast cancer, the early data that was presented almost a year ago now suggests that this improves both how long the patients remain progression-free, but also appears to improve survival for patients with advanced estrogen-sensitive breast cancer. And so we're awaiting further data from this trial. We're also waiting to see whether or not the Food and Drug Administration will give approval to this agent. But again, what looks like progress in this previously hard to treat population of patients. Now, let's move on to the second family of breast cancers that I talked about earlier. And this is the so-called HER family of receptors. HER stands for human epidermal growth factor receptor, which is why we call it HER, as you can imagine. And we're in particular interested in HER2, which is amplified, increased in roughly 15 to 20% of patients with breast cancer, and in many patients with metastatic breast cancer. We've known about this for a long time, and we've been working on this for a fairly long time, I think with real progress over the years. We can measure this in tissues. So when a patient has newly diagnosed breast cancer, not only do we measure estrogen receptor in her breast cancer, we also measure how much HER2 she has in her tumor. And if she has what we call an amplification, where there's a doubling or more of the signal of the HER2 gene in the cancer, that tells us that that's a tumor that has a reasonable likelihood of benefiting from HER2 targeted therapy. Now, the founding father of HER2 targeted therapies was a drug called trastuzumab, which I'm sure is known to more of you as Herceptin. And this is an antibody. An antibody is a protein that's part of the immune system. We make this antibody in the laboratory and then infuse it into patients. The antibody binds to the HER2 molecule, which is on the surface of the breast cancer cell, and basically shuts down the process by which HER2 causes cell division. And we've known for a pretty long time now, for close to 15 years, that if we use Herceptin in the early stage breast cancer population, we can diminish the number of patients who have a distant recurrence of their breast cancer and improve the overall survival of patients with early stage HER2 positive breast cancer. And this is with trastuzumab. We have other drugs now that we know improve benefit above and beyond this. Now, after the early studies in the early stage disease setting, with the realization that we improve things but didn't improve it for everyone, oncologists then asked the question, would it be possible to make advances beyond trastuzumab, beyond Herceptin, for early stage HER2 positive breast cancer? So we went back to the laboratory. And in the laboratory, what you find out is that HER2, which, as I mentioned, is on the surface of the breast cancer cell, likes to hook up with something called HER3. And when HER2 hooks up with HER3, that activates a number of pathways within the breast cancer cell that make the cancer tougher to kill and more likely to divide. And so this hooking up of the HER2s is a problem, but it's a problem that has a potential solution. And that is to say, just as trastuzumab binds to HER2, another drug, pertuzumab, it's also called by its trade name Perjeta, prevents hookups between HER2 and HER3. It acts like the chaperone that gets between the two lovers here in this picture. And so this agent came into the clinic in combination with trastuzumab in the setting of metastatic breast cancer. And it did so in the context of a very large international study called Cleopatra. Cleopatra took over 800 patients and then randomly assigned these patients either to receive a standard chemotherapy drug, docetaxel or Taxotere, along with trastuzumab, or to receive the chemotherapy drug along with the combination of the two antibodies, pertuzumab and trastuzumab. And the results of this trial, I think, impressed most of us who looked at it. And that is to say that patients who added pertuzumab to trastuzumab in this setting added over 16 months in terms of their overall survival in the setting of metastatic HER2 positive disease. Now, to give you some idea of how far we've come in this disease, if we were to go back in time to 1998, when trastuzumab first came along and before which we only had chemotherapy available, the average survival of a patient who had HER2 positive disease was somewhere in the range of 18 to 20 months. So we've added several years of survival to patients with HER2 positive disease with these dual antibody therapies. And I would also point out that if you look at these survival curves and look at the 50% point in terms of overall survival, there are a bunch of patients who are surviving more than 5 years now with metastatic HER2 positive disease. And I think every oncologist who treats breast cancer patients regularly now has patients who are a decade or more out on HER2 targeted therapy. So we are making real progress here. We've certainly got a ways to go, but this has been a real advance. Now, we have other agents that have come along also in recent years. One that I'd like to point out is something called T-DM1. And I've already mentioned that Herceptin or trastuzumab is an antibody. It's an antibody, basically part of the body's immune system, that latches onto the HER2 protein on the surface of the cancer cell. T-DM1 is a really clever idea. It basically asks the question, what if we use Herceptin not just to bind to the breast cancer and to shut off the growth factor pathways, but actually use it as a delivery truck that will deliver a poison to the cancer cells? And so what happened was that Herceptin was bound to this poison. It's called DM1, making T-DM1, which is then absorbed into the cancer cell. Inside the cancer cell, the cancer cell dissolves the linkage between the antibody and the poison, and then the poison is released and it poisons what are called microtubules within the cancer cell. And this approach was tried in the clinic, works, shrinks tumors, and prolongs life. Now, we also have another class of drugs. These are called receptor tyrosine kinase inhibitors. In contrast to the antibodies that we've discussed, these agents actually work inside the cancer cell, work at the business end, what's called the kinase part of the HER2, and by doing so inhibits cancer cell growth. And there's two of these agents here that are on the market. I'm going to show you a third in a minute, but these are an active part of how we treat HER2 positive disease. Now, the third of these kinase inhibitors is a brand new one. It was just approved by the FDA earlier this year, and I think to a great deal of excitement within the cancer community. And it was approved first based on an early stage, what we call a phase 1B trial, where this new agent, tucatinib, was combined with the chemotherapy drug capecitabine and combined with trastuzumab. And what you can see here in what's called a waterfall plot, where everything below the center line is we're looking at tumor shrinkage, is that this combination is pretty good at shrinking HER2 positive breast cancers in patients who've already had prior HER2 positive disease. So that was interesting. Here was the other kind of interesting thing that came out of the initial studies of this disease. This is the first agent that I'm aware of that we've had that gives you a pretty good shot of actually shrinking a brain metastasis. Now, spread of HER2 positive breast cancer to the brain is a real problem. And we see all too many patients whose tumors outside the brain have shrunk and responded to HER2 targeted therapy. But because our drugs in the past have not been very good at getting into the central nervous system, we've done a lousy job of shrinking brain metastasis. Tucatinib appears to be the first agent that we have that's pretty good at actually shrinking brain metastasis. And so this led to a large study. It's called HER2CLIMB, in which patients were randomly assigned to receive the chemotherapy drug capecitabine. You may have heard of it as Xeloda, along with trastuzumab and tucatinib, or just to get capecitabine and trastuzumab. And patients were randomly assigned 2-to-1. This trial, almost uniquely among breast cancer trials, not only allowed, but in fact encouraged patients with brain metastasis to enter the trial. And these could have been patients who have had prior treatment for brain metastasis, or patients who had never been treated for their brain metastasis. And all drugs have side effects, so it's worth mentioning these. Adding tucatinib to this regimen added somewhat in terms of diarrhea, added somewhat in terms of the queases and vomiting that some patients will have, could occasionally cause some inflammation in the mouth, what we call stomatitis. And in a small number of patients appears to increase some liver enzyme activity. Not particularly important in the grand scheme of things, but one of those things we measure. So all new drugs have side effects, and it's certainly worth mentioning these. But what we now know is that when you add this tucatinib, it improves survival in patients who are entered into this trial. This is a good thing. Though the improvement is not huge, it's about a 4-month improvement in this trial, it certainly represents an advance in a population of patients, most of whom had already had prior pertuzumab and prior T-DM1 before they went into this trial. But here's the other exciting thing, I think, for those of us who have looked at this trial. This agent also significantly improves the length of time that a patient with brain metastasis remains progression-free. And if you look over on the right, also appears to significantly improve the survival of patients with brain metastasis compared to patients who get the more standard therapy. And this indeed has been a very unusual thing. This is the first study I've ever seen where we actually can see a significant improvement in terms of survival for patients with brain metastasis. And while we have a long ways to go, I don't want to pretend that this represents a cure for everyone with a brain metastasis. This is a real advance and something that we can build off of in terms of further treatments for patients with spread of the breast cancer to their brain. So an exciting finding. Now, I keep coming back to antibodies because antibodies have been the mainstay of treatment for patients with HER2-positive breast cancer. And I already mentioned T-DM1, which is what we call an antibody drug conjugate, where we use the antibody, again, as sort of the delivery truck for the poison. There's a new kid on the block, a new plant poison, probably a new poison that has been added to Herceptin, to the antibody. Anyone who's actually interested in this, it's called an exatecan derivative. It's related to a group of chemotherapy drugs called TCANs. And this combination, this addition of the antibody to the poison that the antibody carries to the cancer cell, is active in HER2-positive breast cancer and got approved by the FDA again earlier this year for patients with advanced disease. And I've already shown you previously what we call a waterfall plot. And again, by way of memory, everything below this 0 line represents a shrinkage of the breast cancer. And what you can see is that this waterfall plot's pretty impressive. A lot of patients, in fact, the vast majority of patients have a shrinkage of their breast cancer. And essentially, roughly 3 patients in 5 have a confirmed what we call objective response. And we require for an objective response that you have a 30% or greater shrinkage of your tumor. As you can see here, this is a pretty common thing, 3 patients in 5. And indeed, something like 97% of patients have some degree of shrinkage of their tumor or prolonged stabilization of their disease. So again, a real advance. This drug has side effects, has toxicities. So certainly, like all drugs, need to be used carefully. The one that is rare but of some concern is something called interstitial lung disease, where you get inflammation in the lung For reasons we don't understand, this is much more common in patients in Japan than it is elsewhere. But it's important to recognize it, and if we see it, to hold the drug and to treat with steroids to reduce the inflammation. Now, let's move on to the third family of breast cancer, so-called triple-negative breast cancer. And you've already heard a wonderful lecture earlier today about triple breast cancer, so I'll be somewhat briefer here. But again, to remind you, triple-negative means estrogen receptor negative, progesterone receptor negative, and HER2 negative. And this overlaps significantly with a group that we can measure in the DNA that are called basal cancers. And in the past, chemotherapy has been the standard therapy, both in the early disease and in the advanced disease settings. Now, in the early disease setting, this is potentially curative therapy, but in the advanced disease setting, this is a wasting asset. Chemotherapy agents work for shorter and shorter periods of time. The further down the line down you go, and they cost more and more in the way of toxicity. Triple-negative breast cancers are the home of BRCA1 mutated breast cancers. And indeed represent a reasonably sizable component of these cancers. And as it turns out, these are genomically complex tumors. They tend to have lots of mutations in their cancer. Now, here's the problem with calling something a triple-negative breast cancer. Imagine I'm walking down the street and I see this woman on the street, and I'm later asked to describe her to someone. And my description is non-blonde, non-brunette, and doesn't have a beard. Would you accept that as a description? And yet we've accepted that for triple-negative breast cancer. She's not non-blonde, non-brunette, and doesn't have a beard. She's a redheaded woman. And calling things, identifying things appropriately is important because, as you've already heard, if you have an estrogen receptor positive tumor, we give hormonal therapies that target estrogen. If you have a HER2 positive tumor, we target HER2. But if you have nothing but a negative, it's hard to know how to target it. But that's beginning to change, and I'll tell you a little bit more about this. One of the first advances in recent years has been something called PARP inhibition. And PARP is an enzyme that the body uses to fix DNA. One of the things that was discovered a while back was that if you look at patients who have a BRCA mutation, and BRCAs 1 and 2 are involved in repair of DNA as well when DNA is damaged. If you add PARP inhibition, if you shut off a way of fixing DNA, with our quick fix set shown here on the right, and now add that to the underlying problem that cancer cell has of a BRCA mutation, that actually increases your ability to kill the breast cancer cell. And in the laboratory, this was shown very elegantly by Alan Ashworth over a decade ago. This led to the development of a number of drugs called PARP inhibitors. And these PARP inhibitors, for patients who have BRCA1 or BRCA mutated metastatic breast cancers, we now know improve the length of time that patients go before their cancer starts growing again. Now, I view this as a modest advance rather than a huge advance, because the difference here is a matter of a few months. And it's not yet been associated with a major improvement in terms of overall survival, albeit in studies with fairly advanced disease. However, we now have 2 FDA-approved drugs for patients who have a BRCA mutation and have metastatic disease, talazoparib and olaparib. These drugs are also used very commonly for ovarian cancer, where they have a major impact, and increasingly in a number of other cancers where there are BRCA mutations. So in advance, though, I think we'd have to say a modest one rather than a huge one. We're starting to see some mission creep with these drugs, and that is to say, while the original studies focused on patients who had a BRCA1 or BRCA2 mutation, we know that there's a lot of other inherited mutations that are involved in breast cancer. And if you look at a PARP inhibitor for some of these, what you find is that, in particular, something called PALB2, which is a rare but important gene involved in terms of inherited forms of breast cancer. You can frequently shrink breast cancers using the drug that we already use to shrink BRCA mutated cancers. So that's an interesting and exciting finding. And there are larger studies are underway to try to get this involved in a larger population of patients. Now, the other kind of exciting area in triple-negative breast cancers in recent years has been in the form of immunotherapy. And these two gentlemen, Jim Allison and Tasuku Honjo, got the Nobel Prize a couple of years ago for their studies looking at how T cells, the body's first line of immune defense against cancer cells, how T cells work to help kill breast cancer cells and indeed other human cancer cells. And I'm going to go to one of my favorite movies here. This is Star Wars. And I'm going to try and give you some sense of what cancer cells do to T cells. Now, through most of my career, when a patient would ask me, is there something, I got cancer, does that mean there's something wrong with my immune system? My answer was always the same. No, your immune system's fine. If you come down with the flu, you'll feel just as miserable as I do. But it turned out I was wrong. And that is to say that breast cancer cells, and indeed many cancers, are capable of fooling the immune system and telling the immune system, basically, go away and don't bother me. So I'm going to show you this little clip to show you how they do it.
Let me see your identification.
You don't need to see his identification.
We don't need to see his identification.
These aren't the droids you're looking for.
These aren't the droids we're looking for.
He can go about his business.
You can go about your business.
Move along.
Move along. Move along.
And that's exactly what cancer cells do to the body's immune system. And here's how they do it. They have on their cell surface something called PDL1. PDL1 binds to a receptor on the body's T cells, again, the first line of defense against cancer cells. And it signals that T cell, basically, these aren't the droids you're looking for. But what we can do today is that we can toss in an antibody, yet another antibody, that prevents these proteins on the cancer cell from binding to the receptor on the T cell. And all of a sudden, the T cell wakes up and goes, yeah, these are the droids you're looking for, and let me attack the cancer cell. Now, this is still early on, I would say. We don't have nearly as much data as we'd like, and we haven't used it nearly often as we would like, but we certainly already have data in patients who have what's called a PDL1 positive breast cancer, that if you use one of these checkpoint inhibitor antibodies, one of the antibodies that interferes with PD1 and PDL1 binding to each other, that this will prolong the length of time that patients remain progression-free, and it also appears now to improve overall survival for patients with metastatic PDL1 positive breast cancer. So this is exciting. We're still working on this. We have a long ways to go. One of the things we're doing is try now to move these into patients with earlier stage disease and outside of triple-negative breast cancer, where this first observation was shown. But we'll learn more about this over the next few years. Now, finally, another antibody, and this is a drug with a really unpronounceable name, sacituzumab govitecan. And this is another one of these antibody drug conjugates, where we take an antibody against a protein on a breast cancer cell and link it to another chemical, in this case, a drug called SN38, basically a form of chemotherapy. The antibody takes this to the cancer cell, and it kills the cancer cell. And this was looked at after some initial studies in a very large study in which patients with metastatic triple-negative breast cancer who'd had at least 2 prior chemotherapies for metastatic disease were then randomly assigned to receive either a physician's choice of a single-agent chemotherapy drug or to receive this antibody drug conjugate. And what sort of results do we see? Well, this trial, it's called the ASCENT trial, has already shown that we can improve overall survival for patients who are receiving this antibody drug conjugate. And the improvement in survival is roughly in the order of about a half a year. As you can see, looking at the number of months that patients have been followed on this trial, we're not really far enough out to have a good sense whether or not there's long-term benefit for a proportion of patients entered on this trial. Though certainly out as far out as at least a couple of years out, patients appear still to be deriving benefit. And so we're hopeful that this may translate to long-term survival for some patients. Now, I'd like to finish this talk by talking to you a little bit about the genomic revolution that we're in, because we've not only seen improvements in terms of cancer therapeutics in recent years, we've seen real improvements in terms of diagnostics. And this falls under the blanket term of genomics, basically looking at the genes that make up a human cancer. And this is being driven by the fact that the technology has really, really improved. There was a time a couple of decades ago where no matter how hard you tried, you couldn't get this test. The average test cost would have been somewhere on the order of $100 million. But starting a little over a decade ago, the price of this began to fall drastically. So now it's possible to get the gene chips that we need very cheaply, or relatively cheaply, less than $1,000. This price will continue to go down. And this allows us to take a piece of the patient's cancer, to grind it up, and then to measure every single mutational event that occurs inside the patient's cancer. Now, and we can do this in terms of commercial tests. This is a gene list from one of the standard ones that is available commercially, something called Foundation CDX. And this gives you some sense of why we bother to do this. Look way down here at the bottom, there's something called NTRK. It's what's called a fusion gene. It occurs in about 3 patients for every 1,000 patients who have metastatic cancer. It is so unusual and so rare that no one had ever heard of it until a few years ago. But if you have this fusion gene in your cancer, and you get a drug to treat it, and a very safe pill to treat it, 7 patients in 10 will have a major response of their cancer to it. Now, this is just one of several examples that we could give you. We're now doing these increasingly for patients with metastatic breast cancer. And my guess is over time, we'll increasingly use these to monitor genetic changes over time in cancers. But already we're seeing some hints that some patients can get real benefits from this. So again, the diagnostics are improving. And my humble opinion is that a few years from now, we'll be using these routinely in the setting of metastatic disease and using them regularly as the price continues to diminish. Now, when I was a medical student, medical students were taught when you hear hoofbeats, think of horses. And that is to say, common things occur commonly and you better be prepared to treat them. And while that's still true to a significant degree, I'd say now in the genomic era, when you hear hoofbeats, you need to look for zebras. You need to look for the unusual, because increasingly we have new treatments for the unusual, and this will allow us to make advances in this area. Now, Komen, of course, is fully invested in this, and I would be remiss in not thanking all of you for your efforts in supporting the cause. Komen has had a significant investment in metastatic breast cancer research, and to date, we've invested over $200 million in more than 500 research grants and more than 50 trials focused on metastatic breast cancer. Currently, we have 93 active grants, which is roughly half of all of our active research portfolio in Komen. This research invests in world-class leaders through our Komen Scholars Program, but also invest in younger investigators, the next generation of metastatic breast cancer researchers who we think are going to be the leaders in decades to come. We're also supporting big data approaches that help us answer questions and save more lives faster. And I would add that Komen has always been very proud that for every research committee that we have, there's always a patient voice on that committee to help keep us honest and help keep us focused on the prize. What are we investigating? Well, we're identifying the genes and processes that cause breast cancer cells to metastasize. We're helping to develop and test new therapies to both prevent and treat metastatic breast cancer. And we're discovering new methods for predicting the risk of metastasis or detecting metastasis using early blood tests or body scans. The early blood tests in particular are really interesting. They're so-called liquid biopsies, where we can actually measure circulating tumor cells or circulating tumor DNA and use those to help us predict which patients will benefit from which therapy. So that's very exciting. Well, is your head exploding yet? This has been the most exciting time, certainly in my career. We've had more than one new drug per year approved for metastatic breast cancer over the last decade, and the research only continues to pick up. We're getting closer, we're getting better, and I suspect we'll reach a point in the not too distant future where we'll be able to make this a whole lot less frightening as a disease. And with that, I'll come to an end, and thank you ever so much for listening to me, and I would certainly be delighted to answer any questions that you all might have. And again, thanks for inviting me back to Wisconsin.
Hello there. I was just saying welcome and thank you so much. That was a wonderful presentation. How are you today?
I'm great, thank you.
Good. We didn't have a chance to say hello before your presentation, but it went zooming by, and there was so much information. Any before we dive into questions, any thoughts that occurred to you while you were watching and listening?
Well, I always think of breast cancer as having sort of two poles in the year. One is the American Society of Clinical Oncology meeting, and the other is the San Antonio Breast Cancer Symposium. San Antonio meets next week. So my guess is we'll have a whole bunch more to talk about even a week from now. So keep your eyes posted, because I think there'll be several exciting new thoughts and treatments coming forward very soon.
Fantastic. That relates to one of the questions that we've had, and that's somebody asking, how do they stay most up to date with current news as a lay person? Do they need to dive deep into the research, or are there places that you know about that people can go to follow the advancements and follow what comes out of those conferences?
Well, sure. I guess first thing to say is, again, I mentioned the two major conferences every year. American Society of Clinical Oncology usually occurs in the first week of June. San Antonio occurs in the first or second week of December. Those are heavily attended by reporters. So most of the major advances actually show up in your newspaper or show up online. But if you want to speak to your oncologist about what's new, the best time to ask is a week or so after ASCO or San Antonio, because that's when they're going to have the greatest amount of new data to share with you. Got it.
Great. Thank you. A question that came in, you were at the end of your presentation, you're talking about genomics, and somebody is wondering, they are years into their diagnosis as a Mets patient. Is it worth it for them to still be asking their oncologist about having genomic testing at this point in their disease journey?
Yeah, I think it's a great question. And part of the answer is that cancers evolve or change over time. And they frequently change, actually, having started with a certain toolkit. They sometimes toss things out of the toolkit and sometimes add things to their toolkit over time as a result of the treatment that a patient has received. So sometimes a mutation that wasn't there early on will show up later on. I mean, a classic example of that is something called ESR1. ESR1 is the estrogen receptor gene. And if you look at someone who's newly diagnosed with breast cancer, it's astonishingly rare for them to have a mutation in the estrogen receptor gene. But if a patient's been on hormonal therapy for a while with an aromatase inhibitor, she'll frequently have an estrogen receptor mutation. And the difference between having that mutation or not is the difference between not responding and responding to an aromatase inhibitor. So sometimes we get the information, and the information tells us what not to treat with, because no one wants to go on a toxic placebo. Right. So if we can find out what not to treat with, that's a good thing. But also increasingly, I think we're going to use these to help show us what to treat with. I showed this rare mutation, something called NTRK, But there's a number of other mutations that are popping up that we can measure with genomics. A good example of this is something called PIK3CA. This is the gene for what's called PI3 kinase. It's common in estrogen receptor positive breast cancers. If it's there, it means your tumor will respond or has a higher likelihood of responding to a new drug called alpelisib. I think we're starting to see this as sort of a recurring theme in metastatic disease. Cancers change. We can find new things. Not only do the cancers change, but the tools we have to treat the cancers change. I have a patient who, as an anecdote, I'll share with you, who had a triple negative breast cancer. And after going through a number of different chemotherapy agents, she was just about out of options. This was 4 or 5 years ago now. We did genomic testing on her tumor and found that she had a mutation that made you much more likely to respond to a checkpoint inhibitor, something called microsatellite instability high, or MSI high. Mm-hmm. She responded for 3 or 4 years to that. Eventually, her tumor started growing. I actually went back to her genomics and found that she had a BRCA2 mutation, an inherited mutation. When she was being treated early with metastatic breast cancer, we didn't have any drugs to treat that with. Now we've got the 2 agents that I mentioned in my talk. We put her on one of those. She responded for another year or so to that drug. And we now got some more genomics on her and found a new mutation, and we're starting her on a new, we've just started her on a new treatment for that. So sometimes the genetics change, sometimes our drugs change. And so it's reasonable to go back and look at these things. My guess is over the next few years, as we get more into the liquid biopsy sphere, where we can actually measure these mutations, measure the DNA changes in the blood, my guess is we'll probably actually do these as sort of part of our evolving way of looking at the cancer as it responds to treatment.
Got it. That's interesting. You were talking about, you're talking not just treatment updates or its improvement in diagnostics. And I'm wondering, like, as a researcher, when the diagnostics are giving you so much more information, does that make it easier to decide where to strike out next as far as going for research? Or does it make it more difficult to know with all the new things that present themselves? Are there clear paths given to you in that new information?
Well, sometimes the paths aren't clear, but they're still there, or at least some sense of them. Mm-hmm. Let me give you an example. I mentioned in my talk in estrogen receptor positive breast cancer, the CDK4/6 inhibitors. Well, 5 years ago is basically the first time anyone was being treated with those in the metastatic disease setting. Now we're using them in the early disease setting. And the question that's now coming up is, if those stop working, what do we do next? And so there's a huge effort on by investigators around the globe to look at what mutational events occur once someone has been on a CDK4/6 inhibitor for a while. And the idea is, if we find out which events occur, what allows that cancer cell to escape, maybe now we'll be able to go in with something that blocks that in turn and makes those drugs more active. There's the old saying of Francis Bacon, that knowledge is power, is certainly true in breast cancer. Certainly, the more we know, the more we're going to be able to come up with appropriate treatments.
So new treatments often lead to the next treatment by what they're leaving behind.
Indeed.
By what they're not. I see. Okay.
Indeed. I always think of it as slicing a pie.
Right.
As we've gone on, we've sliced the pie into thinner and thinner slices. And we've increasingly treated narrower and narrower segments of patients with more and more specific, more and more targeted, more and more individualized therapy.
Does that delay the overall advancement as opposed to just speeding up advancements into those tiny slices? Or is that an improvement across the whole pie?
Well, no, if you treat one slice, you're treating one slice. But we've had sort of two different stories going on simultaneously. One story is the slicing the pie story. The other story, which is predominantly what we've seen with the checkpoint inhibitors, the new immunotherapy drugs, is more of a therapy that's aimed to be more of a generalized or global therapy for the disease. Okay. So we're seeing, I would say, sort of two parallel tracks going on. Both have benefits. Both are potentially exciting. And we're going to follow both of them because both may lead to cures for some patients.
So the PDL inhibitors, that's not limited to just metastatic cancers then? It sounds like that.
So we now have evidence in early stage breast cancer. There's a large study that was completed a little over a year ago that was published in the New England Journal of Medicine last year that was looking at early stage patients with triple negative breast cancer who had high risk cancers, either large cancers or cancers with a lot of lymph nodes, in which patients received, in addition to chemotherapy, received one of these checkpoint inhibitors. And what was found in that study is that there was a significant increase in the percentage of patients who had what's called a pathologic complete response. In other words, they went into surgery and they had no cancer cells left in their breast or their lymph nodes when they went to surgery. Now, in the past, increasing the path CR rate has been associated with an increased cure rate for patients with early stage disease. We don't have long-term follow-up from these studies, so we don't know yet. But it's a pretty exciting thing, and I think everyone is encouraged.
Right. So it could reduce recurrences.
Indeed.
Okay. One question, you just were talking about CDK4s. Somebody is asking, how do you determine which CDK4 to use for specific patients, and which do you use?
Well, it's hard to say which one to use in the metastatic setting, and that is to say we have three of these agents. Palbociclib, ribociclib, abemaciclib. All three of them have phase 3 trials in both the front line and the second line setting of metastatic hormone-sensitive breast cancer. All three of them have positive trials there. Those trials look relatively similar. The drugs do differ somewhat in terms of side effects. So palbociclib and ribociclib have a bit more in terms of lowering of white blood cells. Ribociclib's got some rhythm disturbance issues for some patients. Abemaciclib has a slightly higher rate of diarrhea. And certainly for some patients, the side effects may determine which drug a patient receives, based on their prior history or based on what comorbidities they have. In the early stage setting, it's a little bit different because in the early stage setting, we've learned literally just in the last 2 or 3 months that abemaciclib lowers the likelihood of having a recurrence for early stage high risk ER positive patients. But unfortunately, palbociclib, which also had not one but 2 trials conducted in the early disease setting, has not shown a benefit for early stage patients. So whereas in the metastatic setting, it's hard to prove that one drug is better than another. In the early disease setting, we've got a fairly strong signal that we should be using one drug and not the other.
Okay. I have a question that I'm not sure I'm understanding. But I'm going to read it to you, and I'm assuming that you will understand it. Okay. What's the next step now after progression from CDK4/6 inhibitor and fulvestrant for HER2 negative HR and BC stage 4?
Okay, so if a patient has an estrogen sensitive HER2 negative breast cancer and receives a CDK4/6 inhibitor plus a hormonal therapy, and now that tumor is growing, what do we do next? I think is the basic question. Well, so partly it depends on what we know about the cancer. So for that patient, one of the very first things we would look at would be, does that patient have one of those PIK3CA mutations that I mentioned earlier? Mutation that causes the cancer to have more of something called PI3 kinase, an enzyme that stimulates the growth of the breast cancer. And if you have a PIK3CA mutation, and that's about 40% of patients now who have metastatic ER positive breast cancer, if you have that PIK3CA mutation, then you can remain on the same drug, fulvestrant, take away the CDK4/6 inhibitor, and then add in a new drug called alpelisib. Its trade name is, which is of course a lot easier to pronounce as always, is Piqray. So that's one population of patients where we have a pretty good idea of knowing what to do. For other patients, there's a somewhat older drug. It's called Afinitor or everolimus. That also can be combined with fulvestrant in that setting, or can be combined with everolimus, with exemestane, one of the aromatase inhibitor, and can cause tumors to shrink and prolong progression-free survival. So I'd say those are kind of the standard approaches for someone in that setting. And of course, as always, I encourage all my patients to look at clinical trials because those trials are frequently allow us to move to something new and exciting, and that may be more individualized or personalized based on the patient's particular tumor. Okay. I mentioned the genomic assays for many patients in the setting that you just described. I would obtain a genomic assay of some sort and see whether or not it showed something new and cool that we weren't previously aware of in that patient's cancer.
Got it. Her follow-up comment was no mutations and no genomic abnormalities.
Oh, you're making it tough for me.
Yes, she's making it rough for you.
Yeah. Well, again,
advanced studies class here.
Yeah. Well, again, exemestane and everolimus are approved in that setting. So that certainly, if the patient wanted to remain on an endocrine approach, that would be the way to go. The other approach would be to move to some form of chemotherapy. And again, the third approach, which I would certainly encourage, would be to see if there are any clinical trials close by that would be available and specific for that particular patient.
Okay. I'm assuming a lot of people know this already, but if you're looking for a clinical trial, where do you do that? How do you get onto those lists, and how do you go searching?
Sure. Well, so one easy way to do it is to look at something called clinicaltrials.gov. You can actually, go in on the internet and Google clinicaltrials.gov, and it has a relatively easy to use menu where you can type in ER positive metastatic breast cancer and push a button, and it will give a list of clinical trials, and along with the list of clinical trials, it will tell which of those trials are relatively close to where you live. If you are fortunate enough to live close, reasonably close to a major medical center, and in Wisconsin, certainly both UW-Madison and the Medical College of Wisconsin would certainly be good examples of that. Both of those places, and certainly other institutions around the state, have clinical investigators who do regular trials in metastatic breast cancer.
Excellent. Another question from a different person. She would like to know if there's anything in the pipeline for HER2 positive.
Yeah, well, in addition to what I've already mentioned, yeah, there's a number of things that are being looked at in terms of HER2 positive breast cancer, and in general, these fall into a couple of different categories. One is further improvements in terms of antibody therapy. There are a number of companies that are actually trying to, if you will, sort of develop super antibodies that actually work better, antibodies that are better in terms of harnessing the immune system to attack the cancer. There are others who are developing new, what we call antibody drug conjugates. I mentioned TDM1 as an example of that, but there's a bunch of others that are currently in development. There are also some novel immune approaches that are probably going to be shaping up fairly soon. And that is to say that while most of our immune approaches have involved either antibodies or the checkpoint inhibitors, which are basically playing around with T cells, there are other cells that are involved in terms of the body's immune system. These include things like macrophages and dendritic cells, and there are a number of investigators in the laboratory and increasingly in the clinic who are developing new agents that will target other aspects of the immune system. And then finally, there's what are known as engineered T cells. These go under the rubric of CAR-T, C-A-R-T. And these are basically T cells that have actually been engineered to attack specific types of cancer cells. And so, for instance, there are CAR-T cells that have been engineered to attack HER2 positive cells that are in clinical trials. So a bunch of stuff coming along. None of these are FDA approved yet. So I don't want to try and jump the gun and say that I know what's promising and what's not. In my own center, for instance, we're doing a trial in which we're looking at a new drug that helps stimulate something called NK cells. Cells are natural killer cells. It's a very bloodthirsty sounding type of drug, but to help attack the breast cancer cells that are HER2 positive. So a lot's going on, and always hard to say in advance what's going to actually what'll work and what won't.
Right. Right.
The joke in medical oncology is that we call it research because we search and we search and we search, and eventually we find something. So,
right. When you're talking about engineered T cells and the kill cells,
natural killer cells, yeah,
killer cells, are these, when you're talking about engineering a cell, is that introducing a new cell into somebody's body, or is that changing cells that they have into something that does something different?
Usually the latter. Usually involves taking out some of the patient's own T cells, for instance, and then engineering those cells, basically typically putting some DNA into the cell that in essence instructs the cell to do something differently than it's used to do, and then infusing it back into the patient's body.
That's interesting. Okay. Another question.
A lot of that going on.
Yeah, that's just fascinating. A question from the beginning, you're talking about triple negative breast cancer. Your example of describing the woman as she doesn't have a beard and she's not 7 feet tall.
Yeah.
As we learn more about triple negative, do you expect that? I mean, right now we think of that as a type of cancer. Do you expect that to divide into multiple families of cancers?
Absolutely.
Not into one or two distinct groups. It's going to turn out to be 17 different pies.
Yeah. So my colleague Jennifer Pietenpol, who's co-chief scientific advisor for Komen, and who's one of the world's great researchers in terms of triple negative breast cancer, her and her group have already done extensive genomic analyses of triple negative breast cancer that have already broken it down to, depending on which paper you read, somewhere between 4 and 6 different subtypes of triple negative breast cancer that you can measure at a genomic level. And knowing that is actually leading to some novel therapeutic approaches for triple negative breast cancer. And so we're getting better at identifying these things. For instance, and some of these things are already things that are in the clinic. I mentioned the checkpoint inhibitors. Those inhibitors only work if you have this PD-L1 thing on the surface of your body's immune cells inside the cancer. So we actually test people to see whether or not their tumors are PD-L1 positive, but before we give this treatment. I mentioned the PARP inhibitors that we give for BRCA mutations. Those only work if you have a particular type of mutation. And so we now measure for mutations in patients to see whether or not they might be beneficial for those patients. I mentioned this new antibody, sacituzumab. Sacituzumab targets a very specific protein that's on the surface of triple negative breast cancer cells. Now, the good news is it's really common on triple negative breast cancer cells. So you in general don't even need to test patients, but to see whether or not they have this TROP2 protein on the cell surface. But increasingly, we're using therapies that are relatively targeted therapies for triple negative breast cancer.
So that would be a place to start, but not a place as a pointer to go where to go next. You'd need to be more individualized.
Yeah, and I think we're going to increasingly do that. I was on a conference call today with I'm a member of what's called the Eastern Cooperative Oncology Group. Actually, University of Wisconsin-Madison is as well. We actually were discussing a novel therapeutic approach for triple negative breast cancer that involves, I think, 15% of patients with triple negative breast cancer. Well, if you think about it, triple negative breast cancer is maybe 10 to 15% of all breast cancers. 15% of triple negative breast cancer then would be somewhere around 2% of triple negative breast cancer. So we're actually developing therapies that are targeting therapeutic approaches that are targeting 2% of breast cancer.
Wow.
We're honing down to a fairly fine point.
I'm checking the questions. I just saw somebody raise their hand. So whoever that was, I encourage you to put your question in writing so we can see it. One other question that came in is, what is the effect of the pandemic had on breast cancer research? Are you seeing delays, or is it letting everybody just focus on their own in their labs and get more done?
Yeah, well, the pandemic's had a number of serious effects. First off, very early on in the first few months, we sent pretty much everyone home who was in the laboratory. And indeed, we also significantly reduced the number of patients who were getting mammograms. And, neither of those is a good thing. And of course, as you have surges in COVID, in different parts of the country, that in turn frequently leads to further shutdowns going forward. It's also, of course, had an effect on organizations like Komen. Komen relies on the support of large populations who are willing to come out for a race for the cure, for 3-day races, and for very good and very appropriate reasons, because we do not want to be a super spreader event. For COVID, Komen has had to shut those down, and that has reduced the amount of money coming in, therefore reduced the amount of money going to cancer researchers fighting breast cancer.
Right.
And that is a significant, profound, and I would add dangerous thing, particularly for our younger investigators who, in many cases, are getting their very first grant to do cancer research from Komen.
Mm-hmm. Okay. I don't believe, okay, here's one more question that's new to me. What about HER2 heterogeneous cancers where biopsies test HER2 positive sometimes, HER2 negative sometimes, HER2 equivocal sometimes even in the same tissue sample?
Yeah, it's a great question. It's what pathologists call tumor heterogeneity, and it's just as if you were to go into a town where 80% of the people belong to some religion, that doesn't mean that everyone in the town does. It may be that they react in a different way. And so if we treat a cancer that is, say, heterogeneous for estrogen receptor or for HER2, and we do a good job of wiping out all the ER positive cells or wiping out all the HER2 positive cells, and what's left are cells that don't have either ER or HER2. Those cells can grow and take over, and now they're a new problem for which we don't have the old treatment. That's a real issue. There's some potential ways around that which are kind of interesting. So one example is we've always thought of HER2 in terms of what we call 3+ by immunohistochemistry. In other words, you have to have a lot of HER2 protein on the breast cancer cell for a HER2 antibody to work for that cancer cell. There are now investigational approaches that are actually looking at sort of super antibodies, in many cases antibody drug conjugates, that we actually might be able to use in tumors that have less HER2, but still some on their surface, what we consider as 1+ or 2+ for HER2. So there are a number of these studies going on right now with some preliminary kind of interesting results. We don't have final results in, they're not yet FDA approved. But the idea that we might be able to actually tackle those heterogeneous populations, the tumors that have a little bit less HER2 in them than the ones that we treated in the past, is an exciting prospect and one that's being actively looked at right now.
Thank you.
Mm-hmm.
Another follow-up question. If you have a PIK3 mutation, but our HER2 insurance doesn't pay for the meds, and it's a very expensive treatment, do you see a change coming in that?
Well, there's certainly a lot of people who are looking at who are actually looking at that in the form of new clinical trials, and so there are trials ongoing in the for instance, in the ER positive, HER2 positive space to see whether or not we might be able to use PI3 kinase inhibitors in that space, combining it with drugs like Herceptin or other HER2 targeting drugs. Again, we don't quite have enough data yet to say that this will be standard of care, but it's certainly a problem that the research community is well aware of and that we're working on.
Okay. Is that typically just a matter of time and recurrence of, like, the occurrence of that situation over and over again to get those payments?
The insurers are, because these are very expensive drugs, and in fairness to the insurer, $12,000 a month drug is an expensive drug, and they have to be careful in terms of how they spend their money. And I might add, for individual patients, of course, the copays that are attached to these can be obscene as well. So we need to be very careful about making sure that our drugs actually work before we commit someone to the side effects and both in terms of toxicity, but also in terms of financial toxicity of these agents. So we need to do our work. We'll get it done. It may take longer than the patients and the doctors would like.
Probably standard practice for that.
Yeah.
Speaking about people with their individual doctors. So if somebody has a relationship with their medical oncologist and they're feeling like the doctor's isn't recommending treatments, that, like, you're saying things and they're not hearing any of this, how do you suggest that they go about introducing their doctors to these ideas, or what do they do at that point? How do they advocate for themselves?
Well, the easiest way, of course, is to get a second opinion, and that, of course, when you get a second opinion at a place other than where you are being seen. And by the way, if someone's going to get a second opinion, don't get it from someone's partner. Right. Get it from someone who's not someone's partner. Then hopefully what will happen is that, well, first, it's possible that doctor, that second opinion may agree with your doctor. That's not uncommon. But if they disagree and they put it in their note and their dictation goes to the physician, that at least gives you a little more ammunition to discuss things with your doctor. Now, at the end of the day, if you're not satisfied with your physician, you certainly have a right to go and find yourself another doctor. I always encourage folks to get second opinions. I would add that the best time to get a second opinion is not when you've just started a new treatment. It's before you started a new treatment. So if someone has a scan that is showing growth of someone's metastatic disease and it's time to switch, that's the best time to go and get a second opinion.
So not just at the beginning of your cancer diagnosis, but it could be years in where you've expired one treatment and you're switching to a new one. That's another opening for a second opinion.
Absolutely. I would add that this is a really, really rough time to be a general medical oncologist. If you go to the Food and Drug Administration's website for new cancer drugs, what you will find is that the FDA has been approving what are called new indications, basically, a drug for a disease, on the order of once per week for the last 4 years.
Wow.
Okay. So imagine being the poor general medical oncologist who, after seeing a breast cancer patient, goes on to see a colon cancer patient, a lymphoma patient, a leukemia patient, and a kidney cancer patient, all on the same day. And they're expected to memorize 52 new indications per year, and maybe 250 over 5 years. And I'll tell you, I'm not that smart. I have to hand it to my general medical oncology colleagues who by and large try really hard to keep up, but it's hard. And so, good cancer doctors are not threatened by second opinions because they may not have gone to San Antonio that year. They probably haven't gone to San Antonio that year. And so they're not up. They may be just a few months out because they have not yet gone to an educational conference that's brought them up to date on that.
Right.
So
right.
Getting a second opinion isn't a criticism of the doctor, and frequently it can be an aid to the doctor.
Okay, so it doesn't necessarily mean you're getting a second opinion and you're choosing a different you're changing doctors. You're just bringing new information to your doctor to see what their response is to that new information.
And indeed, I will say, as the sort of guy who ends up doing second and third opinions, being at a major medical center, far more often than not, what I end up doing is saying, I think your doctor's doing a good job, and I agree with what your doctor suggested to you. But occasionally I'll say, this is pretty new. This is this just came out 2 weeks ago, and your doctor may not have heard of it yet. And here's something that I think might be worth his while thinking about for you.
Got it. We have one more question that came in. Could you mention what major clinical trials might be presently addressing this woman's previous question? What the next step is? Next step after progression from CDK4/6 inhibitor and fulvestrant.
Yeah. Well, so I mentioned some of the trials that are looking at tumors that we don't classically think of as being HER2 positive. And these are tumors that are 1+ or 2+ for HER2. And there's some so-called antibody drug conjugates against HER2 that are being looked at in ER, what typically we thought of as ER positive, HER2 negative patients, but are actually 1+ or 2+ for HER2. So those are certainly ongoing and are exciting. There is a drug that has already been in a phase 3 trial. It's not yet FDA approved. That I encourage people to look at if there's a trial available to them. It's for what's called an AKT inhibitor. It's a drug called capivasertib, which I think is pretty exciting. And then there's a whole new class of drugs that are called oral SERDs. So SERD stands for selective estrogen receptor downregulator or degrader. And there's only one of those on the market currently. It's fulvestrant or Faslodex. It's the pain in the butt drug for ER positive breast cancer patients. But there's a bunch of oral SERDs, basically drugs that are like Faslodex, but are going to be given as pills. That are in development right now. And several of these are in ongoing clinical trials that is certainly worth looking into. Some of these are interesting because, at least in the early going, some of them appear to work in patients where fulvestrant hasn't worked. And so, there's a lot of interest about them in the breast cancer community.
Thank you. I don't have any new questions that have come in, so I'll put out a last call for questions in our final minutes. Any thoughts that you have on something you'd like to share that is swimming around in your head that popped up while we were listening to all these things?
Well, I'll just give you my standard mantra, which is research cures cancer. And, we do all sorts of research. We do research in the laboratory. We do research in the clinic. And indeed, we do research after drugs have reached the clinic just to increase their safety and their efficacy. I think those of us who are interested in wiping out this disease, ending it as a serious public health threat, the only way that we're going to get there is by doing more research. And that research requires funding through organizations such as Komen. It requires the participation of patients, and it requires the energy of physicians. And so anything that you can do to encourage any of those three things is a good thing.
Fantastic. Well, thank you, Dr. Sledge, so much. This has been a fascinating hour and a half. I want to thank you. I want to thank the audience as well for your very nice questions and for staying with us. If you want to see this presentation again, we will have the download of the recording in our hands fairly soon and get it up as quickly as possible. If you're interested, on Thursday of this week, Dr. Leslie Waltke will be with us. She's a physical therapist, and she's going to be talking about weakness and fatigue with NBC and the impact on the quality of life and what to do about it. She has a lot of good ideas for you on that. And Dr. Sledge, tell us before we leave where you are with that beautiful background.
Well, the background is Amsterdam, but I'm actually sitting at home in Palo Alto.
Lovely.
So if I may add one last comment,
Sure.
Go Packers.
Go Packers. They did a good job for us last night.
Indeed. I will say something I will add is that my father-in-law, who's passed, used to be a scout for the Green Bay Packers.
No way.
When Vince Lombardi was coach. So Packers are in the Sledge family.
Way to go. Way to go. Well, it is always a pleasure to talk to you, and we love having you come, in this case, virtually back to Wisconsin. We hope we can do this in the future in person, so we can come running up to you afterwards and shake your hand and all those good normal things that we used to do.
Myself as well. I look forward to it.
Thank you so much. It's been really delightful talking to you. Have a really good rest of your afternoon. And thanks everybody for joining us today. We'll be talking to you soon.
Indeed.
Bye-bye.
Bye all.
Bye.